Alright, so here we have our evidence-based protocol for a grade 3 ACL sprain, which is technically a tear in this case. And we're going to be focusing more on the post-surgical reconstruction and the rehab process behind that. So to start off, how do you get this injury? So the etiology of this pathology, it's basically you're changing direction quickly, or you're cutting around an obstacle, you get that force downward, you're shifting the tibia. Most likely there's a twisting motion, and this can happen even after landing on a jump with a sudden slowdown, so most likely your basketball population. It's been seen in your football population, gymnastics, so many different populations for this pathology. This can also occur when you're falling off a ladder, stepping off a curb, stepping into a hole. Just that mechanism of injury where you're twisting and you're shifting that tibia forward, it's going to cause that ACL to either tear completely, partially, and we also have to keep in mind that there's a high rate of meniscal pathologies that go along with ACL tears. So with that being said, we're moving into post-surgical. We're in the immobilization phase. They're immobilized, they can't really move. So we're going to have a few goals here. We want to reduce the post-surgical swelling of the affected knee so that it goes back to the size of the contralateral side. Over a period of 3 to 4 weeks, we're going to be using the Rice method. And to measure this, we're going to be taking bilateral girth measurements using a tape measure each week. Also with this, we want to minimize the atrophy of the quadriceps, which we know is a muscle that atrophies fairly quickly with ACL injuries. We want to minimize that atrophy over the 3 to 4 week period through even E-stim. We're going to be stimulating or re-educating that musculature and taking bilateral girth measurements of the quads as well each week with the tape measure. Also, we are trying to reduce overall pain in this phase of the rehab through modality use. It's easy to record the patient's pain level. We can use the visual analog scale. But if we're working with a younger population, I kind of prefer the Wong-Baker face scale. It's more child-friendly, and I find that one kind of amusing. So moving on, we're going to modality usage for this phase. Just a brief overview of what modalities there are and whether we should use them or not. So beginning, we have cryotherapy. That's a definite yes. Thermotherapy, no. Massage, yes. Ultrasound, yes, to a certain extent, as well as massage to a certain extent. E-stim as well, certain extent, as well as laser we can use. So looking at cryotherapy, first of all, what does it do? Well, we know that it decreases tissue temp, cell metabolism. That's good. But we also know that it's going to restrict the blood flow, which means we're going to have reduced swelling, which is something that we're looking for in the immobilization phase, which means we also want to reduce that pain. So for this, we're going to apply the ice bag directly to the knee. Note that you can use other forms. I prefer the ice bag. It's easy, it's efficient, it's not costly, but we're trying to reduce that pain and swelling. And we're performing this 4 to 5 days over a period of 20 to 30 minutes. We want those effects to take place where we can decrease that swelling. Thermotherapy, we are going to avoid this, especially in the beginning of phase 1. We know that thermotherapy increases pro-inflammatory activity, so we're restarting that healing process. We don't want that. But we're also increasing blood flow at the wrong time in the injury process, and there's a possibility of secondary injury taking place. Massage, we can use that very efficiently, only in the form of effleurage right now because we want that light pressure. We're going to push that skin towards the heart. We're going to get all that bad stuff out of the knee, have the good stuff come in, but we don't want to put enough pressure where we get some thermal effects because that could possibly jumpstart the inflammatory process again. But the overall message here is we're trying to decrease pain through the gait control theory as well as decrease swelling. We can also use therapeutic ultrasound in this process. It's low intensity impulse. We can stimulate or enhance the healing process. We do not want 100% duty cycle right now, because that involves thermal effects that we don't need. We also have angiogenesis, which means we're forming those blood vessels, we're enhancing nutrient delivery. Overall, we're going to decrease the pain. We can use E-stim in this case right now. We're going to restore strength and endurance to the quadriceps. We're going to delay that atrophy preceding surgery. We're going to re-educate those muscles by depolarizing the motor neurons, your type 2s especially. We're going to develop that muscle tension, which leads to muscle overload here. And we're going to re-educate those muscles and ultimately reduce pain. We can also use laser in this case. It's fairly new, but we're going to be using low-level laser. It's more or less for the wound healing process, as well as we're reducing that swelling and edema and repairing damaged tissue through a facilitatory response, as well as an inhibitory response on how or which mode you want to use the laser. Phase 2 deals with progressive resistant exercise. This is when we have this great deal of tissue healing and we've removed the immobilization. So our goals for this phase, we want to increase range of motion of the affected limb to the same degree as the contralateral side through rehabilitation exercises and modality use, taking measurements with a goniometer. Pretty subjective, we can use that as our measuring tool. Our second goal, reduce patients' overall pain and soreness through modality use and recording that using the visual analog scale like we did in the immobilization phase. 3, we want to increase patients' motivation and confidence levels through encouraging conversations and using positive wording throughout this phase, and taking measurements through the Athlete Fear Avoidance Questionnaire, or the AFAQ. I found this really interesting because I feel that confidence and motivation is an overlooked portion of the rehab process, and I found it really cool that we can somewhat use a questionnaire to figure out the confidence and motivation level of the patient. Modality usage. We can use pretty much any modality in this phase, and here's why. For cryotherapy, we're going to combat that inflammation brought on by these exercises. Some of these exercises can induce pain and later on delayed onset muscle soreness. So cryotherapy would be really great. It can be used at the athlete's discretion. Whenever they feel pain or soreness, we can just apply an ice bag. That would be that. Thermotherapy. This is where we can thrive with thermotherapy. Before activity, we can place a heat pack on them. We can increase their blood flow, which means we're going to have more nutrient delivery. We're going to deform that collagen, so if we add in a stretch, we can decrease muscle spasm, as well as increase range of motion and flexibility. We can massage. We can still use effleurage as a technique, but we can also use petrissage and friction massage as well. Using that kneading technique, we can make a thermal effect just like the heat pack. And we can improve some circulation, increase some blood flow, break up some scar tissue, and their pain will also decrease. We can use therapeutic ultrasound as well. Once again, low intensity pulse. We're making those new blood vessels, increasing that blood flow, nutrient delivery, decreasing pain. But this is where we can use that 100% duty cycle. E-stim. We can combine that with rehab exercises to improve the patient's strength and endurance. We'd like to set it on the neuromuscular electrical stimulation. That's more or less for your pain, and it's great for these first 2 stages of the rehab process. Laser, we're also using that low level. It's mainly for pain control, but we can also boost that collagen production and increase the range of motion. We can also enhance that proliferation phase of that tissue healing where that collagen lines up and beginning to mature. They're healing properly, so we're adding more. So then we're moving on to the functional phase. And we have a few goals here. We're having the patient go through complete and unrestricted participation by providing sport-specific activities and monitoring any abnormalities in the way they walk, the way they function, and their overall well-being. And we can have that recorded using the lower extremity functional scale. In our second goal, we're continuing to increase patients' motivation and confidence through these positive interactions with the patient, encouraging alerts while they're going through rehab, but we're also recording it as well through that AFAQ that we talked about earlier. We can also restore strength of the affected limb to the same level as the contralateral side through rehab exercises and measuring the strength by comparing the weight used on the affected limb and the weight that was used on the unaffected limb. So once again, with modality usage, we're going to use all these different modalities at the clinician's expense. What do they want to use and why? For me, I would use cryotherapy in this case because there still might be some pain, some DOMs still left after these exercises. We can use this as needed. Should be less used in this phase rather than the first phase because there probably won't be as much swelling. And once again, we can use any form of cryotherapy. As well as thermotherapy, we can still deform that collagen, continue to increase that range of motion and flexibility. We can apply this for 10 to 15 minutes. And there's also research that we're starting to find that indicates that thermotherapy is great for fighting delayed onset muscle soreness. Massage, we can use any technique, but we can also use tecpotement now. That is really good for combating DOMs, and it's mainly a feel-good massage, so is it really feasible for the clinician to use when we're on basically a time schedule with other athletes or patients. Therapeutic ultrasound, it's not the prime modality to use, but it's more for pain and tissue healing. So this is another one of those probably feel-good modalities to use in this phase. Not really feasible to the clinician right now, but it's basically desired by the patient at this point. E-stim, I wouldn't say this is the best choice. It's still used for pain reduction, perform as patient desires in this case. It could be also psychological purpose, but most likely superstition. They think it works, but is it really feasible? Laser, we can still use it for our functional effects, our pain control. This one, as well as E-stim, psychological purposes. So we're moving on to our final phase, the maintenance muscular strength throughout. Our main goal for this is to maintain our muscular strength through full body exercises and workout programs. So it depends on how long the patient's with us. Are they with us for a lifetime or only for their sporting career? But during that time they're with us, we can measure their strength improvements through their documentation on how much weight they're using when they work out. Is it full body? Is it resistance training? And so on. But our next goal is maintaining that motivation and confidence throughout the rest of the patient's life through positive words and conversations. But we can also use that AFAC again to measure this. And overall, we want to maintain their quality of life, having those follow-ups with the patient and asking about their lifestyle. And there's the quality of life instrument that we can use to measure that. Once again, we can use all these modalities at the expense of the clinician. If it's feasible, do you have the time? Cryotherapy, good for soreness after activities. This can now be considered a psychological factor in this case, performed as desired by the patient. Thermotherapy, same reason, more of a psychological desire. Be aware that too much increase in tissue temperature could result in decreased force production, so it could have a harmful effect. Massage, this is one of them that isn't feasible for the clinician, definitely. It's basically the patient comes in, they want a feel-good massage again. A lot of psychological things going into play. Therapeutic ultrasound, it's the same as the functional phase, only desired by the patient. It's not very feasible, but you can still use it for the same effects. E-stim, same reason. They like the feeling that E-stim gives them. Laser, also psychological, but you can use it for pain control, functional strength. So in short, there is a time and place for each modality to use. The healing and rehabilitation processes are different and unique to each patient, and we have to be aware of that. Clinicians have different views on different modalities, and using the wrong modality at the wrong time could possibly harm the patient. And we also need to be aware of new research coming out on new techniques and modalities, but we have to verify that the evidence is correct and what it is actually doing to our patient. So this concludes what type of modalities we should use, when to use them, how we should use them, and whether or not they're going to be effective for our patients.